class we had discussed about intestinal obstruction overall, like small intestinal obstruction and large intestinal obstruction. Now we are starting with pathologies related to specifically small intestine. In that, the first one being bowel diverticula. Okay, so what does diverticula in general mean? Diverticula in general means just like a hernia, but a part of the bowel, only mucosa and submucosa will be protruded or herniated. Okay, that is nothing but herniation of mucosa and submucosa. This is called as diverticula. If that happens in small intestine, then that is bowel diverticula. So why does this happen? This happens because of increased intraluminal pressure. So if the pressure here is too much, that is constantly pushing the bowel outwards, then there happens to be a diverticula, which is nothing but herniation of mucosa and submucosa. Okay, this is called as bowel diverticula. So what are the pathophysiology of bowel diverticula? Andre, it is mesentery because of lymphovascular supply, or it can be because of nutrient artery that penetrates the muscularis propria and pushes the bowel outwards. Okay, so this bowel diverticula can be acquired, or it can be multiple, or it can be a false diverticula, or it can be located along mesenteric aspect. Okay, so these can be called as features of bowel diverticula. It is acquired, it can be multiple, and it can be false, and it can be located along the mesenteric aspect. Okay, now this was just a basic idea of bowel diverticula, what exactly happens. So there is one such diverticula called as Meckel's diverticulum. Okay, this is most commonly asked in case of small intestine. Okay, what is Meckel's diverticulum ಅಂತ ಕೇಳಿದ್ರೆ, Meckel is again the name of a person, and diverticula is herniation of mucosa and submucosa. So what are the features? How will this diverticulum be in specific? Andre, it is usually single, it is a true diverticula, and it is congenitally acquired. Okay, it is located along the antimesenteric border. Whatever we studied related to bowel diverticula, it is exactly opposite to that. Okay, it is a here bowel diverticula is usually multiple, but Meckel's diverticulum is single. Bowel diverticula, there is only herniation of mucosa and submucosa, but here entire gut itself is protruded, and hence it is called as true diverticula. Similar to esophageal diverticulum, whichever we had discussed, like Zenker's diverticulum is a false diverticulum because only submucosa and mucosa will be protruded. If all the four layers of GIT are involved, then that is true diverticula. And Meckel's diverticulum is true diverticula because all four layers of GIT are involved, and usually it is along the anti-mesenteric border. So mesentery is just like a curtain holding the entire intestinal loops at one point. Okay, so along the anti-mesenteric border and the opposite border to which the mesentery is attached, there this diverticula will happen. So here, if the mesentery is attached here, the diverticulum is seen in the anti-mesenteric border, and this is known to be the most common congenital anomaly of the midgut. Okay, why does this diverticulum happen? Because of persistence of omphallomesenteric duct. Okay, omphallo means umbilicus, or you can also say vitellointestinal duct. This vitellointestinal duct is an embryological structure. After the kid is born, or after the baby is delivered, this vitellointestinal duct should obliterate. If it persists, it can lead to Meckel's diverticulum. So what are the characteristics? It can be remembered as rule of 2. It is popularly known as rule of 2 diverticulum. So it is seen in 2% population. It is usually of 2 inches in length, and it is usually 2 feet proximal to the ileocecal junction. So if ileum is there and it is opening into cecum, then 2 inches from this ileocecal junction, or 2 feet proximal to this junction, this diverticulum will be happening, and it is usually symptomatic. Patients are only less than 2 years of age, that is children. Okay, so these are the rule of 2. It is seen in 2% population, 2 inches long, 2 feet proximal to the ileocecal junction, and seen in children under 2 years of age. Okay, so ಇಲ್ಲಿ ಏನಾಗುತ್ತೆ, there can be two types of tissue. So since this is a part of a small intestine, only small intestinal tissue should be present. But just like I said, it is an embryological defect. So while developing, there can be an ectopic tissue or ectopic mucosa from the stomach or from the pancreas or from the colon lining this diverticulum. If that is there, you can add one more to this roll of two tissues or two types of mucosas. Most commonly it is gastric mucosa seen here, right? Or there can be pancreatic or there can be colonic also. So two types of tissues can be found. Okay, so what will be the clinical features in case of Meckel's diverticulum? One though, if this ectopic mucosa is from gastric, which is most commonly from gastric, if there is an ectopic mucosa, it will like it is like a lion in a sheep, a lion in a herd of sheep. Okay, so lion won't forget its job. So similarly, gastric tissue won't forget its job. Even present in Meckel's diverticulum, even present in a small intestine, it will start secreting acid. So this gastric substance, which is ectopic mucosa, which is present in Meckel's diverticulum, that will start producing acid in small intestine also. In stomach, there is separate special modification like bicarbonates are secreted more, as like these act as a protective barrier against the acid. So even when the acid is secreted in stomach, the lining of the stomach won't get destroyed. But in intestine, there is no such specific mechanism. So what happens if this acid is produced in small intestine? That acid will damage the mucosa of the small intestine. That will lead to formation of ulcer. Because of this ulcer, it can lead to bleeding also. So most common presentation will be in case if the ectopic mucosa is present, which most commonly will be, and it will be most commonly gastric mucosa. In that case, the patient will come to you with bleeding. Okay. In case of, because in Meckel's diverticulum it is usually children under 2 years of age. In case if the baby is asymptomatic and if it grows into an adult and after that it starts expressing its symptoms, then it can be abdominal pain. Okay, so usually abdominal pain or bleeding will be the most common symptom, and based on that we can diagnose Meckel's diverticulum. Okay, so now why will this abdominal pain occur in adults all of a sudden? From childhood there is no abdominal pain, but in adult why does this abdominal pain happen? That might happen because of some sudden events, like there can be a midgut volvulus, like just like I said, this is a diverticula like this from the midgut. So this might go for volvulus, it might twist around its own because of torsion, then that will lead to sudden abdominal pain, that is midgut volvulus. Then again intussusception can happen. So this it is like telescoping, one part of the Meckel's diverticulum goes into the other, and because of this again here apex will have loss of blood supply, because of which there will be pain and abdominal pain is happening. Other than that, there can be sudden inflammation in this region. Because of inflammation, again pain. So diverticulitis, that can happen. Because of these three reasons, usually there will be pain in adults in case of Meckel's diverticulum. Okay, and one point we have to keep in mind, that is Meckel's diverticulum mimics acute appendicitis. Like there will be fever, there will be vomiting, there will be pain abdomen, usually beginning in the right iliac fossa, just like abdomen, just like appendicitic pain. Okay, so most of us we will think, okay, this is acute appendicitis and this is an emergency condition, we need to operate. So we have explored the patient also, we have started the operation and we have started exploring, and appendix was found to be normal. Okay, so now what surgeons usually should do means they shouldn't close it as it is, they should look for this site of Meckel's diverticulum, that can be a cause which will mimic acute appendicitis. For that reason, where should we search? We should search 2 feet from the ileocecal junction. So once on exploration, if the appendix is normal, we should look for the Meckel's diverticulum, which is 2 feet from the ileum, and only in case if the Meckel's diverticulum is also normal, then there can be some other pathology which we should find out. If only appendix is done and we have closed it, that will be our fault. Okay, so hence this point should be kept in mind, that Meckel's diverticulum mimics acute appendicitis and we should always look for 2 feet away from the ileocecal junction. Okay, so what is a specific investigation? How can we diagnose Meckel's diverticulum per se? That is, investigation of choice for diagnosis is called as technetium pertechnetate scan. This will usually detect ectopic mucosa, whatever is present, and if the ectopic mucosa is detected, then that is almost the diagnosis of Meckel's diverticulum. Okay, suppose there is absence of ectopic mucosa in case of technetium per technet scan, then investigation of choice becomes enteroclysis. This is basically like endoscopy only, right? So what we'll do is we'll push a tube through our mouth or nose, and we'll reach intestine, basically esophagus, then stomach, then intestine, small intestine, and then they'll inject a dye. This is similar to fluoroscopy. ಬೇರಿಯಂನ ಯೂಶಲಿ ಇಂಜೆಕ್ಟ್ ಮಾಡೋದು. ಸೊ ಬೇರಿಯಂನ ಇಂಜೆಕ್ಟ್ ಮಾಡ್ತಾರೆ, ಆ್ಯಂಡ್ ದೆನ್ ಸಿನ್ಸ್ ಬೇರಿಯಮ್ ಇಸ್ ಕ್ಯಾನ್ ಬಿ ಸೀನ್ ಆನ್ ಎಕ್ಸ್ರೇ, ವಿಲ್ ಟೇಕ್ ಸೀರಿಯಲ್ ಎಕ್ಸ್ರೇಸ್. So we inject a dye and we take serial x-rays, and that will lead to visualization of whatever the mucosa and intestine is there, that can be visualized. So that technique is called as enteroclysis, and this is usually done for any kind of small bowel diverticula. Okay, previously also I had told about this. So this is enteroclysis. So for Meckel's diverticulum, once we'll go for technetium per technet scan, which will usually detect ectopic mucosa. If there is absence and we still suspect it is Meckel's diverticulum, then we'll go for enteroclysis. Okay, after the diagnosis, once we have known that there is Meckel's diverticulum in this patient, what will we do? Okay, what is the treatment now? So Meckel's diverticulum with healthy base and with unhealthy base, we can say. Okay, so with healthy base, then that is healthy andrenu, there is no loss of blood supply is still persistent for this base. So in that case, we'll just remove the diverticulum whatever was there, and then we'll anastomose it. Okay, if there is unhealthy base, then we'll have to go for resection, that is diverticula, along with that some part of bowel which was unhealthy, that is removed. So that is resection and anastomosis. Okay, now suppose we are operating on an elective surgery patient who had come for some other pathology, and incidentally we detected Meckel's diverticulum, because usually it will present within 2 years of age. If not, they can be asymptomatic and undiagnosed. In that case, if there is incidentally detected Meckel's diverticulum, then what we should do is should always remove Meckel's diverticulum. Up to 80 years of age, you should, if it is incidentally diagnosed, you should always remove it. That is the treatment. Okay, if left untreated, what will happen? There is increased risk of complication. Almost this has been proven in 12% of patients. So there's nothing wrong in taking it out. Since it is incidentally diagnosed, just take it out. Otherwise there is increased risk. So why take risk when we can easily remove it? Okay, that is what they are saying. Okay, so conditions in which there is increased risk of complications in case of Meckel's diverticulum is if the diverticulum has a narrow mouth, or if it has an unhealthy base, or there is presence of ectopic gastric mucosa. These conditions are most dangerous in case of Meckel's diverticulum. Okay, so this was about Meckel's diverticulum. Okay, so we have discussed what exactly is the Meckel's diverticulum. That is introduction. It is true single, and it is present in the anti-mesenteric border. After that we discussed it is a part of small intestine. Okay, after that we discussed about clinical features, and then about investigations, and then management, and then complications. Okay, what we have to remember is rule of 2 for Meckel's diverticulum. Okay, so this completes one pathology. Next one, we will be starting with superior mesenteric artery syndrome. This is also called as Wilkie's syndrome or Cast syndrome. Okay, superior mesenteric artery syndrome. So how can a syndrome be named based on an artery? Why is the name given so? Okay, we'll come to know. This disease is characterized by compression or obstruction of third part of the duodenum by superior mesenteric artery. Okay, how is this possible now? So this is the anatomy. Okay, now imagine a patient is standing, and this is his aorta, right? And superior mesenteric artery arises from the aorta. Okay, and it is passing in front of third part of duodenum. So normally it should be like this. there is a certain amount of angulation between aorta and superior mesenteric artery, so that in between them there are structures which are healthy, normal. Suppose if this angulation is reduced due to some reasons like this, so avag enagutte, this whatever the third part of duodenum is there, that is compressed between superior mesenteric artery and aorta. Because of this compression, what is happening? All the clinical features which we are going to discuss now is happening because of compression of this third part of duodenum or obstruction, basically small bowel obstruction tarane. That because of superior mesenteric artery, hence the name superior mesenteric artery syndrome. Okay, why does this narrowing of angulation between superior mesenteric artery and aorta can happen andre? It can be because of the loss of fat, which is this yellow tissue which we are seeing here, that is fat. Because of that fat, there is pushing of superior mesenteric artery. If there is loss of this fat, then there will be no cushion for the third part of the duodenum between aorta and superior mesenteric artery, because of which the angle will reduce to less than 20 degree, that is acute angle. Okay, this will lead to compression of third part of the duodenum. So why does this loss of fat happen? Does this happen in everybody? No, it happens in the following predisposing factors. If there is rapid weight loss, suppose a patient is some 108 kgs or 110 kgs and all of a sudden he'll reduce to 50 or 60 kgs. Okay, there is rapid amount of fat loss. So visceral fat will also get lost during that time, and because of that there will be loss of cushioning of third part of the duodenum. Similarly, rapid gain of weight. In these patients also there is loss of fat because fat is not distributed evenly. Okay, so fat will be distributed unevenly, and because of that reason there will be hampered loss of fat in this region. Okay, if there is prolonged immobilization also, in that case fat will be seen as a source of energy, and because of that reason the fat can get digested in case of prolonged immobilization. Other than that, body cast application, for some reasons like if the body cast is applied for some LS belt or something like that, if there is some vertebral fracture, anything like that, if the body cast is applied, that will be put in pressure. So because of that reason there can be compression of this third part of duodenum. Okay, so what will be the clinical features basically? Yeah, colicky pain after meals, because once there is no meal, even if this structure is like this, okay, when the structure is like this, fasting state, so whenever the patient consumes meal, what happens, this will start getting dilated, but there is no enough space for it to get dilated. Because of that reason, whenever he has meals, he'll start developing colicky pain. Okay, and whenever the fetus in flaces is passed, there will be soon after consuming, he'll have that urge to pass fetus and feces and flatus. Okay, so that whatever the dilation is there, that will get relieved and the patient will have relief from pain. Okay, so next, how will we proceed with investigation? Will diagnosis is made by hypotonic duodenography or contrast enhanced CT scan. Okay, this is best. Okay, so how will we manage? It is conservative management. Now we can't do anything. We can just say, okay, if you have lost too much weight, gain some weight. Now for prolonged immobilization, we'll ask the patient to mobilize, and we'll ask the patient to lie prone, that is over his stomach, so that there will be enough space for the duodenum to expand. Okay, so that is conservative management. And what is the treatment of choice actually for superior mesenteric artery syndrome is duodenojejunectomy. So whatever this duodenum is getting compressed here, we'll take it out from below the superior mesenteric artery, and we will anastomose it with jejunum. That is a procedure. Okay, other than that, we can treat it with a procedure called as Strong's procedure. That is, there is a anatomical structure called ligament of Treitz, which is keeping all this duodenum and jejunum in place, which is lifting the duodenum also. So fourth part of the duodenum is mobilized, and hence third part will also be mobilized if this ligament of Treitz is divided. Okay, that procedure is called as Strong's procedure. So this is a treatment for or management for superior mesenteric artery syndrome. Okay, so one more thing we had discussed is annular pancreas. Any doubt idea?
So when we talk about the predisposing factors with the weight loss and weight gain, don't you think extreme cases only hold good because unless he's cachexic, this scenario doesn't fit well?
Yeah.
And about the weight gain, and don't you think visceral fat is not what is lost in weight loss, but more of the peripheral and cortisol induced one?
Definitely, yeah. It's like rapid weight loss, we have no issues, right? In case of weight loss, fat is lost from everywhere. In case of rapid gain of height, sorry, I have told it as weight probably, rapid gain of height. That is lean and thin patients. Okay, in them also, it's like fat will be less only, right? So because of that reason, sorry, probably it's all happening because of, I said rapid gain of weight, it's rapid gain of height. Okay.
Yes, thank you. Makes a lot of sense. Thank you.
Okay, it's sensible now?
Yes, thank you so much.
Yeah.
Please continue.
So yeah, sorry, it's rapid weight loss or rapid gain of height. Because of that, the patient will be lean and thin. Because of that reason, there will be less fat. Okay. So yeah, treatment of choice for annular pancreas and duodenal atresia was duodenostomy followed by duodenojejunostomy. Similarly, here it is just duodenojejunostomy. Okay. So in that cases also, in these two cases also, there will be obstruction of the duodenum. But here what we are doing, we are just taking off that part of the duodenum whichever was having obstruction, and we were connecting remaining duodenum with jejunum. Okay, here just we are going, we are not removing the part of duodenum whichever is obstructed. Entire duodenum is taken away from this obstruction and then anastomosed with jejunum. Okay, yeah. So this was about superior mesenteric artery syndrome. So we knew, okay, so we discussed about introduction. It is also called as Wilkie's syndrome or cast syndrome because of body cast, or it can be because of a person who discovered it, that is Wilkie. Okay, after that we came to know about predisposing factors, that is rapid weight loss or rapid height gain. Okay, so predisposing factors ಆದಮೇಲೆ we came to know about the clinical features, which is mainly like similar to small bowel obstruction because of the compression of the third part of duodenum, and usually the patient will be having pain after meals. Okay, and the patient will be feeling he has to go and pass feces and flatus. After this we discuss about treatment, that is duodenojejunostomy, or we can relieve ligament of Treitz. Okay, so this is usually holding fourth part of the duodenum. So if we divide this ligament of Treitz, that will mobilize the fourth part of duodenum. Along with that, fourth part and third part are in continuation. So divide madadrinda third part will also get mobilized. Because of that reason, it won't get compressed. Okay, so this procedure is called as Strong's procedure. Okay, so this was about superior mesenteric artery syndrome. Now coming to the next pathology, that is gastrointestinal tuberculosis. So this, like other tuberculosis, it is caused by Mycobacterium tuberculosis, other pathology being Mycobacterium bovi, but this has been eliminated by the public health measures which have been taken by the government, like BCG vaccination and all. So Mycobacterium bovis in the tuberculosis ಆಗ ತುಂಬ ಕಮ್ಮಿ ಆಗಿದೆ. It is because of Mycobacterium tuberculosis. Okay, so in India, majority of people usually are infected with Mycobacterium tuberculosis, but because of their good immunity, the infection is cleared off and they don't manifest any symptoms. If in case the immunity is low, there will be reactivation of infection and that will lead to symptoms. And in few cases, the infection will be there, but it will be in the dormant state. Okay. So how does this tuberculosis, which will actually reach gastrointestinal tract? So the first organ, as we all know, that is through respiratory droplets. The first organ involved is lungs. Okay. From there, if the person swallows the sputum, infected sputum, so from the lungs there is infected sputum, and if the person swallows it, then it will come into gastrointestinal tract. So that is what they are saying. Swallowing of the infected sputum will reach the terminal ileum, and there will be, so basically this is an antigen. So this is an infection. So TB bacteria has reached the ileum now, and ileum, there will be activation of immune system over there. Okay, so there will be recruitment of lymphocytes in the submucosa of the ileum. Because of this, there will be oxidative stress, because our immune system is trying to kill this by various mechanisms. So that is by oxidative stress, and there will be loss of epithelium also because of this TB bacteria. This will lead to formation of a classical ulcer called as transverse ulcers. Okay, so basically, whenever we swallow, if a person infected with TB swallows the sputum, infected sputum, then arises a case of gastrointestinal tuberculosis. Okay, so earliest activity of gastrointestinal tuberculosis is seen in the mucosal layer, submucosal layer of the GIT, because this is where the lymphocytes or our immune system is present in gut. Okay, so most common site is being, just like I said, ileum, terminal ileum or ileocecal junction is the most common site. Okay, so there are certain pathological types of TB which are present, which can be stated as ulcerative TB, that is 60% of the cases is usually ulcerative, remaining 10% of the cases is usually hyperplastic, and other cases can be sclerotic or fibrotic. Basically this is pathological. Andre gastrointestinal TB agi, if we take a gross specimen, how will it be visualized? Adar base mele they have done studies and they have classified this. So if there is presence of an ulcer, it is called as ulcerative. If there is hyperplasia of the mucosa of the gut, then it is hyperplastic. If there is sclerosis or fibrosis, that is strictures are there, then that is sclerotic or fibrotic type. Okay, so ulcerative type ಅಲ್ಲಿ ಏನಾಗಿರುತ್ತೆ, usually there will be decreased immunity and increased virulence, which will lead to formation of a transverse ulcer in ileum. In case of hyperplastic, there will be increased immunity and low virulence. So because of this, there will be strong inflammatory response because of increased immunity, and that will lead to mesenteric lymphadenopathy, and there will be caseous necrosis leading to formation of matted bowel loops or bowel wall is thickened. Okay, case of hyperplastic TB, what's happening is because of our own immune system rather than virulence. So TB bacteria damage ಮಾಡೋದಕ್ಕಿಂತ ಜಾಸ್ತಿ our immune system is doing. Because of strong immune inflammatory response, there will be caseous necrosis and formation of matted bowel, which will lead to thickened bowel wall. Okay, here it is case of true virulence. Immunity is less, because of that reason there is more virulence, and that is leading to ulcer here. Okay, in case of sclerotic or fibrotic, there will be multiple strictures visualized in the bowel. Okay, so these were the types of pathological types of TB. Okay, yeah, so usually this will be seen like this. So if there are strictures, then that is fibrotic or stricture type, and these are transverse ulcers or tubercular ulcers. And in case there will be mesenteric nodules, rubbery enlarged mesenteric nodules or lymph nodes will be present. This will be seen in case of hyperplastic. Okay, so these covers the three types of pathological types of GITB. Okay, now what will be the clinical features in case of gastrointestinal tuberculosis? Initially, there will be non-specific signs and symptoms of TB only. What are the non-specific signs and symptoms of TB? There will be evening rise of temperature, there will be low grade fever, the patient will be having night sweats, anorexia, weight loss, everything will be happening. But after, if the patient now has developed GITB, what will be specifically seen is there will be formation of transverse ulcers. Ileum gets hyperirritable because of immune mechanisms. And then whatever the content are going to colon, they will go at a faster rate because of hyperirritable bowel. So peristalsis will be faster, and because of that, this reason, there will be diarrhea. Okay. So later on, at the site of transverse ulcer, there will be formation of stricture, which is a passable stricture, and this will lead to subacute intestinal obstruction. This is like an obstruction, but it is subacute. Like it takes time, more than a week it can happen. So first there will be ulcer, then that will lead to stricture formation. Hence the name subacute intestinal obstruction. Okay. So most common presentation being for all this is abdominal pain because of subacute intestinal obstruction. Okay, so what are the complications that will happen in case of gastrointestinal tuberculosis? That is, acute obstruction can happen because of stricture formation or anything. Because of ulceration, there can be perforation, and there can be fistula formation between the bowels, and there can be a formation of an abscess. Okay. So what are the investigations? How will we diagnose gastrointestinal tuberculosis? Most common lab abnormality being rise in ESR in 90% of the cases. Hence, this should never be neglected. If there is a rise in ESR, there is some inflammation going on in the body. That's an indication. So if there is more than 90% of in more than 90% of the cases, if there is rise in ESR, we have to look for gastrointestinal tuberculosis. Okay. So on ultrasound, how does this appear? It will appear like a club sandwich appearance. Why does it appear like a club sandwich? Because of formation of matted bowel loops with collection of fluid in between. So basically, bowel loops have been attached like this, and in between there is fluid. So bowel loops, matted bowel loops, because of fluid in between, that appears like a club sandwich on USG. Okay. So now what paracentesis? On taking off this fluid and sending it for study or for testing, we'll be able to see lymphocytes, that is more, which indicates that it is a chronic condition. Okay, which will be more than 500 per mm cube. And then protein will be more than 2.5 gram per deciliter, and it will usually be exudate just in case like TB. Okay, serum albumin ascitic gradient. Okay, that will be less than 1, less than 1.1. That again indicates it is an exudate. If SAAG is more than 1.1, it will be a transudate. Okay, and adenosine deaminase will be increased. This is all typical to TB only. So in case of GI TB also, we should just do workup similar to pulmonary TB. Okay, same findings will be seen on case of paracentesis. So investigation of choice again being CECT. Okay, so what will be seen on barium meal follow through is there will be pulled up cecum due to contraction of the mesocolon. Okay, so because of contraction of the mesocolon, the cecum will be pulled up, and because of that, on barium meal follow through, we will be able to see that cecum has moved higher in position, and there is obtuse angle of ileocecal junction, that is called as gooseneck deformity. Okay, okay, this is one. Then the other feature being there will be narrowed appearance of ileum due to hyperirritability. Okay, and this sign is called as Sterling sign. There will be persistent narrowing due to strictures, which is called as string of Cantor sign. So this is being third one. In chronic cases, if there is a thickened ileocecal valve, then rigid cecum and narrowed ileum, then that is called as umbrella sign or Fleischner's sign. Okay, this all can be seen on barium meal follow through. Okay, I don't know how much I'll be able to explain here. String of Cantor sign, we can see like it is appearing like a string. Ileocecal junction alli string tara ಕಾಣಿಸ್ತಾ ಇದೆ. This is ileum. Then from here it is a string, and then this is okay. So these are the 4 signs which we can appreciate on barium meal follow through. Okay. In this Sterling sign and string of Cantor sign are seen both in GI TB as well as Crohn's disease. Basically, it is saying that there are multiple strictures. That stricture, we can't identify the cause basically, but we can say it is present over there. That stricture is present over there. Okay. So how do we treat this case of GITB? Treatment is basically for TB what we'll do, anti-tubercular drugs, same thing we'll do. Other than that, we'll just manage the complications whichever is happening because of GITB. If there is acute obstruction, we have to manage that. If there is perforation, again surgery and manage it. If there is bleeding, do the treatment for GI bleeding. If there is an abscess, drain the abscess. If there is a fistula formation, we'll go for fistulectomy. Okay, so this was about GI tuberculosis. We have discussed introduction. After that, most common site and pathological types. That clinical feature, and then investigations, then management, basically treatment and management of complications. Okay, next one being carcinoid tumor. So carcinoid tumor is a neuroendocrine tumor. Okay, so neuroendocrine tumor, basically it arises from neuroendocrine cells that can be present in most of the sites. That is being enterochromaffin like cells in the small intestine. It can be from the argentaffin cells or amine precursor uptake and decarboxylation cells, epid cells basically, and then Kulchitsky cells. These are the cells which arise from the neural crest cells, you can say. Okay, so these cells arise from there, and if there is tumor arising from these cells, then that is called as neuroendocrine tumor. And we are discussing a specific type of tumor in the small bowel, that is carcinoid tumor. So what is the most common site for carcinoid tumor is bronchus, and then being ileum, rectum, appendix, colon and stomach. You can remember by the name BIRAX, that is bronchus, ileum, rectum, appendix, colon and stomach. This is the order for most common site of carcinoid tumors. So there is combined incidence of carcinoid tumor also, that is duodenum, jejunum, ileum. All three are combined more than bronchus. So most probably all three can be involved, and this will be the most common rather than bronchus. Okay, so hence overall most common site becomes all three combined is nothing but small intestine. So overall most common site for carcinoid tumor becomes small intestine rather than bronchus, and then comes all other individual parts of the small intestine. So what are the types of carcinoid? Based on the location of the tumor, we have divided it as localized carcinoid tumor and non-localized carcinoid tumor. So localized carcinoid tumor, it can be localized to larynx, ovary, appendix and rectum. In case of non-localized, pancreas, then colon, then small intestine. So GI carcinoid with best prognosis is carcinoid of appendix, because we can just remove it off. Okay, but overall best prognosis is larynx. In case of gastrointestinal tract, the best prognosis is related to appendix. Non-localized, just like I said, it can be from pancreas, colon or small intestine, and carcinoid with worst prognosis is carcinoid of pancreas. Okay. Most common site for carcinoid tumor in GIT is ileum, whereas in hindgut it is for rectum, and in foregut it is GIT. So basically foregut, midgut and hindgut. We are discussing about small intestine and the most common sites. Okay, after this, based on location of the tumor we have discussed. So based on argentaphic cells or arigophilic cells, based on that there are types of carcinoid, that is foregut carcinoid, that can be argyrophilic, that is it produces low levels of 5-hydroxytryptamine, that is serotonin. Okay, midgut carcinoids are usually argentaphic, and hindgut carcinoids, they have both, mainly argentaphinic and then some argyrophilic. So this produces low levels, this produces maximum, and this rarely produces. Okay, so based on the serotonin, carcinoid tumor, all the clinical features will be there. Hence it is important to know which tumor, which carcinoid will have how much level of serotonin. Okay, so here foregut and hindgut carcinoids are rarely associated with carcinoid syndrome. That is what they are saying. Okay, usually it will be seen in case of midguts only, and that is associated with MEN1 syndrome also in 10% of the cases. Okay, So basically the risk of malignancy is dependent on location, size, depth of invasion and growth pattern. What is the manifestation of carcinoid syndrome? How will the patient present is most common is flushing. This is happening because of serotonin. So serotonin is associated with, okay, it will mainly exert its effects in liver, lungs and brain. Okay, this is where it is getting metabolized, and for metabolism of serotonin we need an enzyme called MAO, okay, monoamine oxidase. So this, on metabolism of serotonin, it will form 5 hydroxy indole acetic acid and this will be excreted in urine. This is the basic pathophysiology. Okay, so in this case what happens is this MAO enzyme is limited. Okay, you suppose 100 serotonin idre, that can be neutralized by this MAO enzyme. In this case what is happening is, because of a tumor which is producing increased amount of serotonin, suppose imagine there is 500 cells, 500 units of serotonin being produced, it can neutralize 100, remaining 400 whatever is remaining, that will start exhibiting its efforts, okay, effects. So because of that reason there will be increased vasodilation which is leading to appearance of flushing. Okay, and similarly there will be wheezing, bronchospasm and diarrhea. Intense desmoplastic reaction around the tumor will happen which leads to excessive fibrosis causing the compression of the lumen, and that will mimic the features of intestinal obstruction, because of which there will be abdominal pain. Okay, so most common symptom is again abdominal pain, and most common site of metastasis of GI carcinoma is liver. And then catabolism of serotonin usually occurs in pulmonary capillaries. So right side of heart is mainly affected, which leads to tricuspid valve involvement rather than pulmonary valve. Okay, so most common valvular abnormality ಏನಾಗುತ್ತೆ ಈ ಕೇಸಲ್ಲಿ ಅಂದರೆ tricuspid regurgitation leading to pulmonary regurgitation or tricuspid stenosis and pulmonary stenosis. So what is a peculiar feature of gastric carcinoid? That is bright red patchy flushing because of increased serotonin. Okay, so how will we diagnose it? Yeah, that is based on estimation of 5 hydroxy indole acetic acid in urine. If there is more amount of 5 hydroxy indole acetic acid in urine, that is an indication that there is more amount of serotonin breakdown, that says that is carcinoid syndrome. Okay, so ಇಲ್ಲಿ ಕಾರ್ಸಿನಾಯ್ಡ್ ಸಿಂಡ್ರೋಮ್ ಏನಾಗ್ತಿದೆ ಅಂದರೆ ಮಲ್ಟಿಪಲ್ ಸಿಸ್ಟಮ್ಸ್ ವಿಲ್ ಗೆಟ್ ಇನ್ವಾಲ್ವ್ಡ್. ಓಕೆ, ಬಿಕಾಸ್ ಆಫ್ ದ್ಯಾಟ್ ರೀಸನ್ it is like we are seeing heart involvement also, we are seeing GI involvement also, we can see brain involvement also. Okay, so basically it is a systemic disease syndrome which involves multiple systems, hence the name neuroendocrine tumor. Okay, so investigation, yeah, based on estimation of 5 hydroxy indole acetic acid in urine. If it is elevated, then that can lead to carcinoid syndrome. In neuroendocrine tumors, whenever we study about any neuroendocrine tumor, initial investigation for localizing and staging is usually somatostatin receptor scintigraphy. ನಾವು ಇದನ್ನು ಇನ್ಸುಲಿನೋಮಾ ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ. ಇನ್ಸುಲಿನೋಮಾ, ಗ್ಯಾಸ್ಟ್ರಿನೋಮಾ ಇದೆಲ್ಲ ಡಿಸ್ಕಸ್ ಮಾಡುವಾಗ ಐ ಹ್ಯಾಡ್ ಸೆಡ್ ಎಕ್ಸೆಪ್ಟ್ ಫಾರ್ ಇನ್ಸುಲಿನೋಮಾ, ಫಾರ್ ಆಲ್ ಅದರ್ ನ್ಯೂರೋಎಂಡೋಕ್ರೈನ್ ಟ್ಯೂಮರ್ಸ್ ವಿ ಕ್ಯಾನ್ ಗೋ ಫಾರ್ somatostatin receptor scintigraphy. That is the best initial investigation. So here also it is a neuroendocrine tumor, again we can go for somatostatin receptor scintigraphy. Okay, whereas the best investigation is dopa PET scan. Okay, now after diagnosis of carcinoid syndrome, how will we treat this? We'll go for segmental resection and en bloc lymphadenectomy. Like basically whichever the segment is involved, that segment is removed, that tumor is removed. Okay, and then if it has spread to any lymph nodes, we'll remove those also. Okay, in advanced cases we can't remove tumor. In that cases we'll go for chemotherapy, that is by DEF, that is dacarbazine, epirubicin and 5-fluorouracil. This regimen is used. Other thing we can do is targeted radiotherapy. So we'll target that particular tumor and start with somatostatin analog that delivers radiation specifically to the carcinoid tumors. That can be done by indium labeled pentriotide, okay, which is selectively taken up by carcinoid tumor, and then this can lead to localized delivery of the radiotherapy to tumor. Okay, so this is important ಅಷ್ಟೇ. ಪೆಂಟ್ರಿಯೋಟೈಡ್ ಅನ್ನು ಯೂಸ್ ಮಾಡಿ ಇಂಡಿಯಂ ಲೇಬಲ್ಡ್ ವಿಲ್ ಗಿವ್ ಟಾರ್ಗೆಟೆಡ್ ರೇಡಿಯೋಥೆರಪಿ ಟು ಕಾರ್ಸಿನಾಯ್ಡ್ ಟ್ಯೂಮರ್ಸ್. ಸೊ ಪ್ರೋಗ್ನೋಸ್ಟಿಕ್ ಮಾರ್ಕರ್ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಏನಂದರೆ ದಟ್ ಈಸ್ ಕ್ರೋಮೋಗ್ರಾನಿನ್ ಎ. ಇಫ್ ದಿಸ್ ಈಸ್ ಪ್ರೆಸೆಂಟ್ ಇನ್ ಬ್ಲಡ್ ದೇರ್ ಕ್ಯಾನ್ ಬಿ ಅ ಗುಡ್ ಪ್ರೋಗ್ನೋಸಿಸ್. ಸೊ ಮೇನ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಬಂದು ರಿಸೆಕ್ಷನ್ ಆ್ಯಂಡ್ ಅನಸ್ಟಮೋಸಿಸ್ ಅಷ್ಟೇ. ಯಾವ ರೀಜನಿಂದ ಟ್ಯೂಮರ್ ಬರ್ತಿದೆ ಆ ರೀಜನ್ ಅದನ್ನು ತೆಗೆದುಬಿಟ್ಟು ಅನಸ್ಟಮೋಸ್ ಮಾಡಿದರೆ ದೇರ್ ವಿಲ್ ಬಿ ಗುಡ್ ಪ್ರೋಗ್ನೋಸಿಸ್. ಸೊ ಓಕೆ, ಇವಾಗ ಇದು ನ್ಯೂರೋ ಎಂಡೋಕ್ರೈನ್ ಟ್ಯೂಮರ್ ಹೆಂಗಾಗುತ್ತೆ ಅಂದರೆ ಇಟ್ ವಿಲ್ ಕೀಪ್ ರಿಕರಿಂಗ್ ಬಿಕಾಸ್ ಆಫ್ ದೋಸ್ ಸೆಲ್ಸ್. ಸೊ ಫಸ್ಟ್ ಟೈಮ್ ಬಂತು ವಿ ಹ್ಯಾವ್ ರಿಸೆಕ್ಟೆಡ್ ಆ್ಯಂಡ್ ಅನಸ್ಟಮೋಸ್ಡ್. ಅಗೇನ್ ಸೆಕೆಂಡ್ time we resected and anastomosed. Again third time we resected and anastomosed. If this keeps happening after so many resection and anastomosis, the treatment of the patient may develop short bowel. So basically entire bowel is almost about 6 meter long. After completely doing resection and anastomosis resection, there can be only a 1 meter of bowel left, which will lead to short bowel syndrome. So what happens in short bowel syndrome? It is caused by massive resection of small bowel, normal length being 6 meters. And if the length of the bowel is less than 2 meters, then we will call it as short bowel syndrome. Okay, what all conditions may lead to short bowel syndrome due to massive resection is there can be mesenteric ischemia, mesenteric trauma, midgut volvulus, Crohn's disease, and just now we have discussed that is carcinoid. Okay, so what are the after effects of this? There will be megaloblastic anemia because of terminal impaired absorption of the B12. So B12 is absorbed in terminal ileum. If there is resection of terminal ileum only, then there will be impaired absorption of B12, which will lead to megaloblastic anemia. There will be impaired enterohepatic circulation also, because these bile salts whatever are there, they are reabsorbed in the terminal ileum. If that is resected, then that will lead to impaired enterohepatic circulation, that lead to increasing cholesterol gallstones. Again there will be malabsorption because of the same reasons. Then oxalate stone formation will be increased because free oxalates will usually be absorbed from colon. Since we have taken out most of the gut, it will lead to oxalate stone formation. Then choleritic diarrhea, that is watery diarrhea due to irritation of colon by bile salts. And then ileocolic valve is removed, that will lead to reflux of fecal matter leading to bacterial overgrowth and diarrhea. So these are the after effects, or these are the complications which can happen because of short bowel. So in case of short bowel syndrome, what is the immediate treatment? Immediate treatment is again conservative management. Instead of giving food through gut, give it through parenteral nutrition, through IV fluids or somewhat like that. And then treatment of choice is actually small bowel transplantation, that is from someone else transplant the small bowel. Okay. So yeah, there are certain procedures which are used for lengthening the intestine, that is called as intestinal lengthening procedures, that is Bianchi procedure and STEP, that is serial transverse enteroplasty procedure. This Bianchi procedure is also called as longitudinal intestinal lengthening and tailoring. The name itself suggests everything. Longitudinally lengthening the intestine because there is short intestine now. Okay, ಇಷ್ಟು ಗೊತ್ತಿದ್ರೆ ಸಾಕು. Yeah.